Manuela. I'm going to speak about artifacts in pediatric records. It doesn't. Artifact that I'm going to speak about is electrofolding artifact. It shows like this here, and it's a temporary loss of signal because of pulling of an electrode away from the skin, which results in sudden impedance change. It can be defined as abrupt vertical deflection, which do not modify background EEG activity and are confined to the affected electrode. See, the other channels are normal. If not corrected, there is inability to read the EEG channel that is popping. As a correction, the technician should reapply conducting gel, should replace the affected electrode, or switch to an alternative derivation. In pediatric population, we can hide the channel when we score because we have to balance between the quality of the record and the fact that the child can wake up and we can interrupt and disturb his sleep. Electrode popping is seen in the channels containing electrode M2. This demonstrates that M2 is the problem electrode. Note that the artifact is synchronous with airflow, suggesting that the electrode M2 is moving with each respiration. For example, here in certain softwares, we can refer EOG to M1. And this will get rid of the artifact. The M1 it's a correct lead here. 60 Hertz artifact. So it looks like this, the dark lines, which are in the second image, they are corrected. So dark consistent pulses that occur 60 cycles in 1 second results from poor electrode contact, defective lead wire, inadequate grounding, or nearby electrical equipment. May be seen in EEG, ECG, EOG, or EMG channels. If not corrected, it's hard to stage the record, establish sleep onset or REM onset. As a correction, technician should reattach a electrode and ground, check the impedance, turn off electrical equipment, check connection to the box, but if all else fails, apply 60 Hertz filter. So here it was applied a 60 Hertz filter and the artifact corrected itself. Oximeter artifact is oxygen level reading 0 or lower than expected. A sudden drop, especially after a body movement, points towards artifact. For example, if the oxygen drops from 99 to 70 all of a sudden, or drops to 0, like in this image, it drops to 0. A gradual drop when the patient is asleep points towards a real desaturation. For example, 99, then it goes 98, 96, 95. It's a real desaturation when it happens during sleep. The cause is that pulse oximeter probe is no longer on the patient. Children have thin fingers and probe might slip and slide. If not corrected, it's not possible to score some respiratory events, so AHI will be lower in the end. As a correction, technician should reapply or change the oximeter, remove nail polish, or try a different location such as stove. So this is in this image, in this epoch, oxygen drops to 0 and it should be marked on as an artifact. Here in Etobicoke, sleep technologists check the oxygen saturation with a portable oximeter just to make sure the oximetry is accurate during night. Overamplification, it happens in pediatrics with high amplitude slow waves. Correction is decreased the gain, channel gains. Unhooked amplifier, we see especially when patient is going to the restroom. All channels suddenly become flat for a long period of time. It's no possible PSG. As a correction, we should check all connection between the patient and amplifier. So this is the unhooked amplifier, and the study is not possible to continue this way. Defective respiratory belt. Just look here at the abdominal belt. Flattened effort channels despite good respiratory effort occurs when a belt is loose or malpositioned. Both the chest and abdominal belts should be positioned in sync. Correction, tighten or reposition the belt or change the belt. So abdominal channel is the problem. ECG artifact. QRS waveforms appear in EEG, EOG leads at the same rate as ECG. So this is the image. So it's symmetrical in all EEG and ECG channels, and they are aligned with the EKG. If not corrected, this is hard to assign sleep stages, and we have to differentiate ECG artifact from spike activity. Spikes usually don't appear in all the channels. They appear randomly. It can be frontal spikes or central spikes. These are more, the ECG artifact is more symmetrical. Correction, reposition ECG electrodes higher up on the chest. Reposition the reference leads M1 and or M2 on soft tissue area, so on the bone. A jumper cable between an M1 and M2, here with the G3. Or average EEG and EOG channels or Natus or Sandman, a software that let you do it. So this is the artifact. Cardioballistic oscillation. Respiratory effort wavers at low amplitude above and below baseline at the same rate as patient pulse. Generally seen during the central apnea event. Or might increase the pressure during the CPAP titration. For example, yeah. So this is how it looks when respiratory effort wavers at low amplitude above and below baseline at the same rate as patient pulse. Is seen during the central apnea events here and here in G3. If we don't recognize this artifact, we might score as obstructive apneas and not as centrals, and patient might get a wrong diagnosis. He might get severe OSA instead of severe CSA, and the physician might refer him for a CPAP instead of brain MRI. And we can miss the diagnosis. And even during the CPAP, if we increase the pressure, the central apneas will become more and more severe, and the problem is not corrected. So they might score central apnea as an obstructive event, or might increase the pressure during the CPAP titration. The correction is position effort sensors away from the heart muscle of the patient when possible during setup. Tech should practice artifact recognition to correctly label respiratory events, or no other correction is possible or necessary. So these are the cardioballistic oscillations. Pulse artifact. It looks like this. EEG and EOG signal wafers above and below baseline at the same rate that patient's pulse, caused by movement of skin surface with arterial pulse. Small amplitude, low frequency waveform that corresponds to the pulse rate. Correction, reposition M1 and M2 of pulse point. So it's somewhere M1 or M2 on a vein, next to a vein or an artery. And that's why it happens. Pacemaker artifact. Spikes occurring in the EEG typically, but may be seen in EEG and EOG. Typically will not see heart rate variability with respiratory events. This is how it looks. It appears in ECG and also in EOG channels. Might cause difficulty with sleep stages. We have to check patient's history for presence of pacemaker. And as a correction, double reference M1 and M2 leads together to reduce the spikes in EEG and EOG. No correction is possible or necessary for EKG. We can average channels or get rid of this. Muscle artifact. This is the muscle artifact when the patient is very tense. High frequency artifact typically seen in EEG and EOG channels, easy to distinguish from the background. It's from increased muscle activity when patient is not relaxed. Generally resolves when muscle relaxes and no correction is needed. Movement artifact. This is the movement artifact. It's in sudden brief bursts of high amplitude, high frequency activity seen across multiple channels. It's caused by muscle activity and tension on wires. If tech does not recognize the artifact, they may disturb the patient unnecessarily. A best strategy is to wait and watch and reposition the leads that might come off. So this is how the screen looks like when the patient is moving. A rhythmic movement disorder includes body rocking. The child may rock his entire body while on hands and knees. It may also occur when he rocks his upper body while sitting up. Head banging. This often occurs with the child lying face down. He lifts his head or entire upper body. Then he forcibly bangs the head back down into the pillow or mattress. This action is repeated over and over again. It may also occur when the child is sitting up. He will bang the back of his head against the wall or headboard one time after another. And head rolling, when the head is rolled back and forth. This is how it looks, rhythmic movement disorder. And this is foot movement, foot tremor. Bruxism, high frequency rhythmic pattern in EEG, EOG, and chin leads, caused by muscle activity in scalp and jaw. Patient might be chewing gum. If that does not recognize the artifact, he might disturb the patient trying to troubleshoot. This is the rhythmic pattern seen in chin, EOG, and EEG channels. If bruxism is loud, it can be heard even on it can be signaled even on the snoring channel. Eye movement artifacts, most notable in eye and frontal lids. No correction is needed. It includes reading eye movements, blinking, Prozac eyes when a patient is on SSRI, which is an antidepressant, or prosthetic eye. This is reading eye movements when the child is watching iPhone or a tablet, or he's reading a book. Blinking eyes seen during biocal when we see blink your eyes, move eyes left to right, but blink your eyes. And prosthetic eye when there is a glass eye, so there is no signal in the first channel. So we have to rely on the right EOG and the chin and all the other aspects for REM sleep scoring. Prozac eyes, we might confuse with the REM sleep, but with Prozac eye, for example, if it's stage 1 or 2, the chin will be high, and the REM it will be low. A sweat artifact, low frequency oscillation seen in EEG and EOG channels. Frequency of the oscillation is much lower than the respiratory rate, caused by perspiration, which can alter the ionic composition of the conductive phase. If not corrected, it is difficult to assign sleep stages, especially M3. As a correction, decrease room temperature, turn on fan and remove the blankets, clean between electrocytes with alcohol, filtering like low frequency filter to 1 may decrease slow waves and should not be used the first. This is the sweat artifact. Respiratory artifact. Slow frequency waveform that looks similar to respiration is caused by respiratory effort of the patient, which moves the leads. If not corrected, it is difficult to assign sleep stages. As a correction, make sure the patient is not lying on wires. It may resolve with a change in body position, reposition, or re-reference effective electrode wires. So this is the respiratory artifact. It's aligned with the respiration, if you notice. Snoring artifact. Intermittent high-frequency dark signal that is usually in chin-EMG channel and occurs at the same rate as patient snoring. Usually corresponds with inspiration, is caused by snore vibration, which carry over to other signals. No correction is necessary. So here the snore is reflected in the chin, but it occurs at the same time, so it's easy to recognize. For example, here I talked about spikes or ECG artifacts. Here the spikes are not occurring in all the channels. It occurs randomly and they are not aligned with the ECG. So in this picture, there are spikes. EtCO2 artifact, usually values lower than 35 millimeter mercury caused by oral bleeding, nasal obstructions, nasal secretion, removal of nasal cannula, and tidal waveform signal should show a plateau, like here. And tidal CO2 is showing a plateau, either here when is the artifact or the patient removed the nasal cannula, or he has oral breathing. It decreased, CO2 decreased from 37 to 25, and it should be marked as an artifact. And CO2 weight doesn't show a plateau. Fish mouthing artifact. Fish mouthing artifact relates to low amplitude false breaths that are recorded by thermal airflow during an apnea. So basically the air enters the mouth where it gets heated, and the airflow picks this signal. The present can result in misclassification of an obstructive apnea as an obstructive hypopnea. They can be identified by concurrent monitoring of end-tidal CO2 or by video, like we see the child how he's obstructing, and the screen shows a hypopnea instead of an apnea. The apparent breaths are produced by air being blown into the patient's mouth as the mandible retracts during expiration against an occluded airway, where it is briefly warm, then flowing out of the oral cavity as the inspiratory musculature relaxes during the expiratory phase of the respiration cycle. There is no correction for this artifact, but it can be seen very well on video. So that would be all.